The heart rate is higher, heart rate higher, stroke volumes lower, cardiac output depends on the heart rate until the heart muscle is fully developed. That's around the age of 5. Innocuous murmurs. Heart murmurs are funny things too for babies because when you do a newborn admission, which you'll do when you do maternal newborn, and you'll hear and you'll say, oh, this baby has a heart murmur. And it could just be transitioning. So you're hearing a murmur, you're hearing a swish. And by the next time you do your assessment or an evaluation, there's no more heart murmur. So that's all closed up and you're not hearing a murmur. Certainly there are murmurs that stay and they'll do an echo and see what kind of the extent of it is, but you have the heart murmurs. Sinus arrhythmias, normal in infants, congenital defects are present at birth. The greater the defect, the more severe the clinical manifestations. So we talk about several of them. A normal heart anatomy, blood flow, and you can see, the circulation, it gets oxygenated through the lungs, then out to the periphery, out to the vascular system, and then back to be reoxygenated. It's a whole system that you learned in anatomy and physiology. For little ones, it's a tiny bit different. For our purpose, we do test you on a lot of the congenital heart defects. And there are several ones to think about. So increased pulmonary blood flow, or acyanotic, increased flow to the right side of the heart. That increases the pulmonary blood flow that at the expense of the systemic blood flow. Then decreased pulmonary blood flow is the cyanotic. So acyanotic and cyanotic, desaturated blood shunts from right to left, causing desaturation of the systemic flow. And then there's an obstructive, though the blood flow meets a narrowing and or obstruction in the heart and causes there to be an interruption. So you have the patent ductus arteriosus, tetralogy of Fallot, a coarctation of the aorta, and the transposition of the great vessels. So those are generally the 4 that we talk about. So congenital heart disease, right to left, shunt is cyanotic, the 4 T's. So it'll be tetralogy of Fallot, the trunctus arteriosus, transposition of the great vessels, or tricuspid atresia. And if you see left to right, shunt acyanotic, atrial septal defects, ventricular septal defects, patent ductus arteriosus, and coarctation of the aorta. So this heart, that picture is a really good one. And this Zoom site lets you listen. So I hope you can hear this, because let me look one more time here. It says more, share sound. Okay. So we have cyanotic and acyanotic. Cyanotic, increased pulmonary blood flow, decreased obstruction of blood from the ventricles. And then the acyanotic is mixed blood flow and pulmonary increased mixed blood flow, decreased pulmonary blood flow. I'm going to hear this one real quick. You can hear it, right? It's only
Welcome
7.
to this video tutorial on pediatric cardiac conditions. Cardiac conditions can affect individuals at a very young age. In this video, we will look at some common cardiac conditions of childhood. A congenital heart defect is when the heart or blood vessels near the heart don't develop normally before birth. There are at least 18 specific types of congenital heart defects, but diagnosis and treatments continue to advance, making it possible to fix most problems. Some common heart defects you may come across include aortic valve stenosis, which is narrowing or obstruction of the aortic valve, causing the left ventricle to hold trapped blood and build up pressure. Pulmonary valve stenosis. The pulmonary valve is narrowed, causing an obstruction to blood flowing from the right ventricle. Atrial septal defect, or ASD. This is a hole in the wall separating the atrium. Ventricular septal defect, or VSD. This is a hole in the wall separating the ventricles. Coarctation of the aorta. This is a narrowing of the aorta which carries blood to the body. This can cause high blood pressure or heart damage. Patent ductus arteriosus, or PDA, is an unclosed hole in the aorta which is normal for the fetus, since blood does not need to go to the lungs to get oxygenated. However, this hole is supposed to close when the baby is born. Congenital heart defects can sometimes improve without treatment, or may be so small they don't require treatment. However, most of the time, congenital heart defects are serious and require surgery and/or medications, such as diuretics or digoxin, which strengthens the contraction of the heart. In some cases, surgery is required to restore circulation back to normal, sometimes requiring multiple surgeries. Most patients require specialized care from a cardiologist throughout their lifetime. Heart failure simply describes a heart that is not functioning properly. It hasn't stopped working yet, but it's not working as well as it should. Heart failure in children is either caused by overcirculation, when blood is mixing inside the heart due to a congenital heart defect, or pump failure, when there is damage to the heart muscle and it no longer contracts normally. Possible symptoms of heart failure in children include trouble breathing, excessive sweating, poor feeding or growth, low blood pressure. Many of the causes of heart failure can be repaired or treated with medication, especially as newer techniques and medications become available. Heart murmurs are common in children and are usually innocent or harmless. They often disappear as the child reaches adulthood, but some adults still have them. A heart murmur may also be an indication of a problem. Murmurs are often caused by defective heart valves. If a valve can't open or close completely, regurgitation occurs. Murmurs can also be caused by congenital defects as well as fever and anemia. Arrhythmias, also called dysrhythmias, can occur at any age and many times they have no symptoms. They can cause the heart rate to be irregular, fast, or slow. Many of the same arrhythmias that affect adults can also affect children. It is important for the arrhythmia to be properly diagnosed so it can be properly treated. The nurse should teach the parent important things to know for a child with an arrhythmia, including CPR, checking the child's heart rate, knowing how to slow the child's heart rate, knowing what to avoid, and understanding the child's medications or pacemaker. Cardiomyopathy is relatively rare in children and refers to a disease state of the heart involving abnormalities of the muscle fibers. There are 4 types of cardiomyopathy, including dilated or congestive. This is the most common type. The heart muscle dilates, causing abnormal contracting and pumping. Hypertrophic. The heart muscle is abnormally thick. Restrictive. The relaxation or filling phase is very abnormal. And miscellaneous or rare. Each type has different clinical features and treatments. Rheumatic heart disease is a rare condition in which permanent scarring of the heart valves is caused by rheumatic fever. Rheumatic fever usually occurs in children ages 5 to 15 that have had an inadequately treated or untreated strep throat infection. Prevention is the best treatment for rheumatic heart disease. Antibiotics can usually treat a streptococcus bacterial infection, or strep throat, which will prevent the acute rheumatic fever from developing. Children that develop rheumatic fever are often given ongoing antibiotic treatments to prevent subsequent inflammation of rheumatic fever and lower the risk of heart damage. If heart valve damage does occur, surgical repair or replacement may be necessary. Kawasaki disease, or mucocutaneous lymph node syndrome, is a rare childhood disease that causes inflammation in the walls of blood vessels. It is most common in infants and young children and is characterized by fever, rash, conjunctivitis, swelling of the hands and feet, swollen lymph glands in the neck, and irritation and redness of the mouth, lips, and tongue. The cause of the disease is unknown, but it may be the result of an infection triggering an autoimmune response. The heart may be affected, causing damage to the coronary arteries and to the heart muscle itself. Kawasaki disease is treated with aspirin to reduce fever, rash, joint inflammation, and pain, and to prevent blood clots from forming. Also, IV immunoglobulin therapy decreases the risk of developing heart disease. Reassure parents that there is no known prevention for the disease and there is nothing they could have done to prevent it. The goal in treatment is to make the child as comfortable as possible while the illness runs its course over 10 to 14 days. Cholesterol and high blood pressure is another heart issue that can affect children of all ages. Buildup of fats and cholesterol in the arteries begins in childhood and progresses slowly into adulthood, often leading to coronary heart disease, the leading cause of death in the United States. Cholesterol levels and the risk for coronary heart disease are affected by eating patterns and genetics. Children can also develop high blood pressure. It may be associated to lifestyle-related factors, such as obesity, or it may be hereditary. The high blood pressure can also be secondary to certain diseases or some medications. The American Heart Association recommends that all children have yearly blood pressure checks to allow for early detection and intervention. The nurse should teach parents and children about healthy eating habits, regular aerobic exercise, reducing or avoiding obesity, discouraging cigarette smoking, and treatment of high blood pressure and diabetes. Thank you for watching this video tutorial on pediatric cardiac conditions. Be sure to check out our other videos and follow us on social media.
She is pretty good. I do like her. This one's only 5 minutes, so listen to this one.
Learning medicine is hard work. Osmosis makes it easy. It takes your lectures and notes to create a personalized study plan with exclusive videos, practice questions, and flashcards, and so much more.
This one's my favorite.
Try it free today.
Osmosis.
The atrial septum separates the right and left atrium of the heart, and an atrial septal defect describes where there's some opening in a baby's heart between these two upper chambers. But how does this opening form? Well, let's first run through how the septum develops in the first place. When the heart's first developing, a tissue called the septum primum between the left and the right atria grows downward, slowly creating two separate chambers by closing this gap, or ostium primum, which means the first opening. This septum primum then fuses with the endocardial cushion and closes the gap completely. Meanwhile, a hole appears in the upper area called the ostium secundum, or second opening. Now we also have the septum secundum, which grows downward just to the right of the septum primum and covers the ostium secundum like a curtain, leaving a small opening called the foramen ovale, and essentially creating a makeshift valve that allows blood to go from the right atrium to the left atrium, but not the other way.
The developing fetus gets oxygenated blood from the placenta, which goes from the umbilical vein over to the right atrium, which is different because after development, only deoxygenated blood goes to the right atrium, which is then sent to the lungs to pick up some oxygen.
In the developing fetus, though, it's already oxygenated, so instead of going to the right ventricle and to the lungs and back to the left atrium, it just bypasses the right ventricle and lungs through the foramen ovale and into the left atrium. The oxygenated blood then goes to the left ventricle to be pumped to the body. At birth, the septum secundum and septum primum slap shut and then fuse and close off this foramen ovale, so we can rely on our own lungs for oxygen. An atrial septal defect, or ASD, describes a condition where in some way the septum between the right and left atrium doesn't close up all the way and remains open even after birth.
Most ASD cases are due to the ostium secundum, which can happen when the secundum septum doesn't grow enough during development. This actually accounts for about 10 to 15% of all congenital heart defects and is the most common congenital heart defect in adults. Fewer ASD cases are due to the ostium primum, where the first opening, or ostium primum, doesn't make it all the way down, again leaving an opening between the right and left atria.
This primum type of congenital defect is found in around 25% of patients with Down syndrome. Atrial septal defects, in general, are also commonly associated with fetal alcohol syndrome. Okay, so there's this opening in the septum. Now what? Well, you know how pressure's higher on the left side than on the right? Well, this pressure difference causes blood to be shunted from the left atrium to the right atrium, meaning more oxygenated blood gets over to the right side, which is usually deoxygenated blood, right? This type of defect is an acyanotic heart defect, which means not blue, since oxygenated blood is going into the pulmonary circulation and essentially taking an extra trip to the lungs. In contrast, a cyanotic heart defect allows deoxygenated blood to bypass the lungs and make it out to the body, causing a blue or purplish discoloration of the skin, which is not the case here. That being the case, you'll see an increase in oxygen saturation of the blood in the right atrium, the right ventricle, and the pulmonary artery. This extra blood volume passing by the pulmonic valve also causes a delay in the closure of the pulmonic valve relative to the aortic valve closure. This slight delay can be heard via auscultation as a splitting of the S2 sound, as well as a systolic murmur in some cases. One potential complication for patients with an ASD is if the patient develops an embolus, let's say a blood clot because that's the most common type, that makes its way through the ASD. So if we take the example of a person with a deep vein thrombosis, part of that blood clot might break loose and become an embolus, And usually this guy would travel into the right atrium, then the right ventricle, and then be pumped off to the lungs and lodge somewhere in the lung. It's possible that the embolus crosses over to the left side, in which case it can enter the systemic circuit and potentially lodge in the brain. This situation is called paradoxical embolism. Paradoxical because the embolus starts off on the right side, but then crosses over into the left side. Sometimes children with ASDs will be monitored for a little while, since smaller openings might close on their own. In other cases though, especially for larger openings, surgery will be done to prevent complications in the future, which typically involves plugging or patching the opening.
Alright, as a quick recap. An atrial septal defect is a congenital heart defect where the septum between the right and the left atrium doesn't close up all the way, and remains open after birth. This causes oxygenated blood to get into the pulmonary circulation. One complication from this condition is paradoxical embolus, which crosses from the right to the left side via the ASD. Thanks for watching. If you're interested in a deeper dive on this topic, take a look at osmosis.org, where
We
we
don't
have
need a deeper
flashcards,
dive.
questions.
I just like the way he goes over everything. So the goals for nursing care with congenital heart disease kids, we don't do heart surgeries at Cottage, but we do take care of several kids in the long term that live this way, that have gone to Children's or Cedars and had cardiac conditions that needed surgery. Reduce the workload to improve the function. We improve the respiratory function, maintain nutrition to meet metabolic demands and promote growth. That's a hard one. That's a hard one for babies and little kids. Little kids more so, but babies, they do get like maybe the breast milk with added nutrients to the breast milk, formula with added nutrients to that formula. We try to prevent infection and then support and instruct the parents. And you'll find out that with kids with cardiac conditions, the parents are really generally up on everything. They know exactly what med works. They know exactly what the medication, when to take it, how the child will respond to it. It's really interesting to see, no matter what walk of life, when it comes to your kid and these cardiac conditions, how the parents or caregivers are very much involved. One of my friends has a child, had a child with Down syndrome that had the atrial septal defect that corrected on its own. So once the child had gone to the cardiologist several times, they were getting ready to do a surgery to close that spot, and come to find out it had corrected on its own. Like, they think miracle. It was a miracle. And she's 17 years old and doing beautifully. So it's just a condition that just depends. General nursing interventions is, of course, to improve the cardiac function, and it's usually with medication if it's not, a surgical procedure. And the digoxin that helps the pump of the heart. Promote fluid loss, so medicate with the diuretics, the potassium sparing, so you have furosemide, spironolactone, or the chlorothiazides, and then fluid restricting, daily weight. We monitor their eyes and nose, and that's all part of your plan of care when you have one of these cardiac patients. We get them on PEDs all the time, and they're pretty well managed. But like, let's say a kid that's had the cardiac surgery gets a pneumonia secondary. That means that, yes, they are going to be monitored quite closely. A decrease of cardiac demand, so promote rest. We minimize the stress, meaning like not super aggressive videos and things on television, keep the lights down, keep the room not too hot, not too cold, just all the different stressors that would be, in a hospital room. A lot of ins and outs into the patient's room. We kind of try to choose our battles, go in and do what you can, then get out. So it's not a lot of outside stressors, I guess. Monitor the vital signs and the temperature, elevate the head of the bed so that they're not working so hard. Sometimes they'll be on oxygen, not all the time. For an infant, nipple versus the gavage feeding or the gavage dropper, that means that it's sometimes more difficult for them to breastfeed. Breastfeeding is a lot of work for these babies. So what they'll do sometimes is just do a gavage roll. They'll put a tube down and then maybe just put a nipple there, but the tube they'll be pouring the formula or the breast milk into the tube, and it'll be going directly into the stomach, and the baby will be sucking slightly. So there's all these different ways, and then of course putting more calories into the food, so that because they do burn a lot. She talked about cyanotic and acyanotic, and so did he. So left to right is acyanotic, and there's the PDA, ASD, and VSD. So patent ductus arteriosus, the atrial septal defect, and ventricular septal defect. So you'll see an increase in the fatigue. You'll hear a heart murmur that sounds like a swish, like whoosh. They're at risk for an endocarditis. So oftentimes they are pre-medicated for any procedure, because an inflammation or an infection in the heart can be, of course, another problem, a CHF, and then growth retardation. So that would be the acyanotic. And you see here the picture that he showed, a picture, but this is kind of just, I don't know, I kind of like the slice this way so I can kind of visualize it, the atrial septal defect. Patent ductus arteriosus, where you see here, this circle area where they're kind of like a bit close together. And then ventricular septal defect here, where it did not close all the way.
Linda,
Yes.
is there ever a time when they detect this and they just monitor it, or do they always?
Yeah, that's what she said. Sometimes it doesn't mean that, it means sometimes it can correct itself, or it's not a cause for a surgical procedure. They can monitor it and give the patient medication for it. So
Yeah.
it's,
So we always give medication though. There's never a time when we're like,
for a newborn, I haven't ever given medication yet for like a murmur, if that's what you're talking about. But for these, it just depends on the case. I'm sure there are some that are so slight that no medication is necessary.
because my anatomy professor had this and like they didn't know he had it. And I like the technology wasn't there for it. And he like grew up fine. He's like over 6 feet tall. Like there was no issue with it. So I was just wondering like if the interventions have changed based on technology.
Well, they change all the time, and that's what she was saying. She even said, things are getting so advanced. So sometimes you hear about people like the man that you're talking about that have lived completely fine all their lives, and like maybe a 45-year-old in the gym and drops dead, and they'll say it was a cardiac issue that he didn't know about. That happened to a physician in Santa Barbara, and I remember it so well. Great guy. And he didn't know he had a cardiac defect. So everybody's different. I mean, that's an interesting question, but hard to pinpoint. I mean, there could be people walking around with a lot of things that are non-detected. And it's interesting for somebody that's as large as he was, 6 foot something, to be, oh, there's a kitty, to be able to sustain, their cardiac hemostasis with a condition.
Yeah.
So it may have been just a slight condition, who knows?
I guess was wondering in terms of patient education, because I feel like there would be a lot of parents who maybe aren't that keen to start their child on heart medications, like if there were alternatives.
Well, but symptoms would be, and two, in the hospital, you do a CHD. So you're looking at circulation of the heart now at 24 hours of age. For all babies, they have to do a CHD. If they're not oxygenating properly, they get an echocardiogram. So there are a lot more advanced things done for babies, infants at birth to detect anything like that. So yeah, interesting. That is interesting. A coarctation of the aorta. So you see where it's kind of got that closure, and that can cause the regurg, like they were saying. And then stenosis, aortic stenosis. So cyanotic, we did the cyanotic defects, 4 T's, tetralogy of Fallot, truncus arteriosus, transposition of the great vessels, and tricuspid atresia. And cyanotic congenital heart defect is right to left. Acyanotic, left to right. An example of the tetralogy of Fallot, we see these children squatting. They have like kind of a blue tinge around their lips or fingertips. You probably won't see their feet when they're at school, but they get short of breath, they get syncopal episodes to where they get lightheaded and sometimes faint. You see a kid kind of squatting on the playground. And when I did that horrible, what is it, yard duty for my grandkids, that's rough. Kids are rough out there, man. I didn't appreciate any of that. But I did see a little girl squatting just like this one. She was in the corner. She was kind of winded. She was kind of just looking around and observing. It looked like she was breathing okay, but had like a tiny little struggle. And here came her worker. And I said, is she okay? Oh, yeah, she has a heart condition. And she was like, okay, I kind of figured that. And, I mean, they do go to school. They do get, probably cardiac meds, but they are kind of watched, and they do kind of have, a condition where they are less active than the other children. Here's a pulmonary stenosis. So stenosis meaning the closure or buildup. And you see here where you say right ventricular hypertrophy, ventricular septal defect here, and overriding aorta. These pictures, I just wanted you to see how they look. And transposition of the great vessel. So you see here deoxygenated blood and then the oxygenated, but it's kind of crossed over. The rheumatic fever is one that's interesting. And if you've had rheumatic fever as a child, you sometimes will have problems with your valve. Your mitral valve can get damaged. It is an acquired heart condition that is after usually a strep infection of inflammatory disorder that you would have involving your joints, your heart, joints, connective tissue, and central nervous system. And the biggest residual effect would be complications with your mitral valve, and you have a leaky valve. Peaks in school age children, linked to environmental factors or family history. It depends on the degree of the damage, but it's also something that you live lifelong with. And a lot of times you'll see when in the ICUs, when they're doing a valve replacement, it is secondary to a childhood rheumatic fever. And here, an acute rheumatic fever is an illness that follows a strep infection. And it gives you just, a little layout of what happens. I do know somebody that has a leaky valve secondary to a rheumatic fever, and you can look at that. Clinical manifestations of the rheumatic fever would be a carditis, inflammation of the heart, polyarthritis, erythema marginatum, subcutaneous nodules. So you have the nodes there and the chorea. Minor manifestations would be a fever, an elevated sedimentation rate, and elevated C-reactive protein. Those are lab tests. But secondary to the rheumatic fever would definitely be those valve conditions. Rheumatic heart disease, treatment of streptococcal tonsillitis, pharyngitis, ordered antibiotics, take your pills as ordered. That's a big one. And then any kind of invasive treatment, like any teeth cleaning, like an endoscopy, a colonoscopy, you need to take prophylactic antibiotics, because if any slight bug gets into the bloodstream, it can go right to the heart, and you will have, a definite problem if there's an endocarditis or an infection in the heart. Kawasaki disease. Hold on one second. No. Unknown cause, less than age 5, systemic vasculitis, increased risk of a myocardial infarct or an aneurysm. Pretty scary stuff. It is a fever greater than 5 days, extremity changes, peeling in the hands, and the tongue gets bright red, a rash, and then the swollen lymph nodes. I was going to put this one on, but let's see. Yeah, this one's only 5 minutes, so let's take
Kawasaki disease is a type of vasculitis that affects medium blood vessels.
So it's a type of vasculitis, or an inflammation of the vasculatures.
It was first discovered in Asia by a doctor named Tamasaku Kawasaki. And since then, it's been noted to affect mostly children of an Asian descent. As I mentioned, it was first discovered by a doctor by the name of Tamasaku Kawasaki in January of 1961. With the first diagnosis, he actually had no clue what was going on, but he did note that patients typically had a fever, along with a body rash and rash elsewhere. The rash seemed to affect the mouth, the eyes, and on the palms and the soles. He also discovered that some rash was a body rash. When Dr. Kawasaki first saw this disease, he didn't know what it was, so he diagnosed fever of unknown origin. This is a blanket term given when a patient has a fever that is not found to have a diagnosis. However, after encountering a lot of patients with rash in their mouth, red eyes, maybe on their body, and on their palms and soles, Dr. Kawasaki decided to publish about this disease, and thus we have the name Kawasaki disease today. Now, Dr. Kawasaki stated that since the symptoms were so clear-cut, he felt that they were pretty close to a discovery of the cause. But unfortunately today, we actually still don't understand what causes Kawasaki disease. And the geographic and genetic influences are still really unknown. Now, as the years have gone on, Kawasaki's disease has also been given the name mucocutaneous lymph node syndrome. It's quite a very long description, but it actually really makes sense based off of the findings and symptoms. The word mucocutaneous refers to mucous membranes. Mucous membranes are wet surfaces such as the mouth, and cutaneous refers to skin. So, for example, skin on your hands or on your feet or on your body. Another mucous membrane affected is the eyes. Now, where does the word lymph node come from? Well, commonly in this disease, you can see swelling of nodes in the neck. These are lymph nodes. Specifically, they're known as cervical lymph nodes. Cervical means neck. Now, as I mentioned earlier, this is a medium vessel vasculitis. A vasculitis is an inflammation of blood vessels, and it's believed to be caused by the immune system, though why the immune system decides to damage the blood vessels in this disease is really not known. The diagnosis is essentially based off of the clinical symptoms that you see. You can see red eyes, which is known as conjunctivitis, a more prominent redness of the mouth. This is oral erythema. You may see redness of the palms and redness of the soles. And you may also see a red body rash. So the common theme in this is rash, red rash. So now if we see some sort of rash or redness, and we also see a fever more than 5 days, and a child is less than 5 years old, you should be thinking about Kawasaki disease. Now, this is actually a disease that's very important to diagnose early. The reason for that is you can see symptoms affecting the heart if this disease continues for a longer period of time. Remember, Kawasaki disease is a vessel disease, inflammation of blood vessels. So if you see damage to some of these blood vessels, you can get clots in the blood vessels of the heart, which causes the heart to not be able to contract. So maybe it can contract well up here, but down here, it's not contracting as effectively. Remember, heart cells need blood, and if they're not getting their blood, they're going to die, and they can't contract anymore. This cell death of heart cells is called myocardial infarction. Myocardial infarction. This is also known as a heart attack. Along with myocardial infarction, you might have cell death of the valvular muscles. These are known as the papillary muscles of the heart. If you cause damage to these, you're not able to pump blood effectively out of the heart because the valves are damaged and not functioning properly. Something more severe that might be seen is known as pericardial effusion. Pericardial effusion is a collection of blood outside of the heart. This is caused by blood vessel rupture. Blood pours out of the heart because of a ruptured blood vessel and accumulates around the heart. This is a very serious issue. And so it makes sense if you see a kid with fever who's less than 5 years old and has all these red rashes, you should be very serious about considering Kawasaki disease. Now, since we don't understand the cause behind Kawasaki disease, using a mnemonic may help you remember the symptoms. I like to remember a kid on a motorcycle, a Kawasaki motorcycle, driving really fast. And when he drives really fast, he gets his heart rate going really quickly. And he drives a motorcycle using his feet and his hands. And so this may help you remember the rash on the hands and the feet, as well as the heart symptoms. Remember, it's linked to Kawasaki disease.
I like that guy too. He's pretty good. I can't say that we've seen any kids with Kawasaki at Cottage since I've been there. I do know the treatment is IV gamma globulin, aspirin, 100 milligrams per kilogram a day, and a quiet environment to treat the symptoms of the illness. That I would think would be a very frightening thing because your heart is so involved. It can be damaged by that. This red mouth and those red eyes is also another, a lot of times symptoms overlap. So if you see those red eyes, the red mouth and the red hand, sometimes you'll think of hand, foot, and mouth disease, where the kids get those blistery hands and they get red and they get peely. But this is much more, because it can involve the acute systemic vasculitis, it can involve the heart. It's a lot more intrusive and a lot scarier. So a fever greater than 102.2, a cervical lymphadenopathy, and you'll feel like if you feel the lymph nodes in the neck, you might not be able to feel them, in the elbow area, but usually you can feel those two lymph nodes underneath your throat, in your throat area. Skin layers start to peel the soles of your hands and feet, a peripheral edema, the conjunctivitis and the lethargy is scary, but the red mouth is very scary. And then bringing a child in, they get put on a heart monitor. And if there is like a cardiac condition going on, they're very concerned about having a heart attack or a myocardial infarct. So not a condition that we want to take too lightly. I haven't seen it at Cottage, but I'm not saying that they haven't had it there. Again, with the pediatric patient, has anybody gone to peds yet? Not yet. They come next week, I think, the following week, a week or two. I don't know, maybe one more week. When you get to peds, it's going to be one of those, I don't know, you're going to see a lot of different things, but if you do see anything like this, please do write it up, because it is something that is really, it's important to see. We'd like to see what's going on. And I just feel like a lot of times we don't get to see it. We don't get to see all the things that we want to see in peds. Certainly we don't want kids to, be in bad conditions or anything like that, but it is interesting when you get a case. Coming up next, we're doing the hematology quite quickly, and we did this already in, can you see my screen? Still sharing? The hematology, you will see kids with different things. I have never seen Kawasaki's. I've seen almost every other thing that we have to talk about so far, but these different things that you'll see, please do write them up and let me hear what you think about your experience was. One thing I want to mention on the last few slides is you are taking care of the whole family. You're not just taking care of that child or that infant. You're taking care of the whole family, because remember what a scary diagnosis for a young parent to have, any parent or caregiver to have, and to, especially when it's a sudden onset, you get a kid with these conditions, you just don't know. I mean, you're born, the baby's born, and now with those super vigilant ultrasound machines, the high technology, you can kind of see a cardiac defect, and they're kind of doing cardiac surgeries when the infant is in vitro. There's so many things going on now that are different from before, but still a parent is never ready for that. Never ready for a congenital defect. We had a baby last Thursday when I was in clinical, and the baby had not all the fingers on the left hand, and the pinky finger and the next ring finger were kind of stuck together. They're fused together, so we're not sure. And the baby did have several ultrasounds, and maybe the hands were, like this, and they didn't notice them, which is really strange for those high intensity ultrasound machines, but we don't know. I mean, I don't know what kind of intervention is done. I know that one doctor said the one hand, which was the right hand, and if it was, the right-handed infant was right-handed, that they could do a surgery, and they felt with all the tests and the ultrasounds that they did that there was they did have knuckles, but the other hand didn't have many fingers. I think it only had two. So just little things like that. And that infant was on a cardiac machine and had to go to the NICU because they did think that there was some cardiac involvement. So just different things you're going to see. Some are kind of unsettling, hard to see, but the baby was beautiful. It was a beautiful little baby. Hematologic symptoms, pediatric variances. All bone marrow in a young child is involved in the formation of the blood cells by puberty. Only the sternum, ribs, pelvis, vertebrae, skull, and proximal epiphysis of the femur and humerus are involved in blood cell formation. During the first 6 months of life, fetal hemoglobin is gradually replaced by adult hemoglobin. And we will definitely see kids in the hospital. I know 3 of them right now that have sickle cell disease that live in North County. One, I think, is Arroyo Grande, and the other 2 are from Santa Maria. And these children, it's a normal red blood cell that has a flexible round shape that you'll see a round blood cell, but a sickled cell is just like that in the shape of a sickle. It has the normal red blood cell, normal shape. It's like a disc. It carries the oxygen to the tissue. And then if it's a sickle cell, it's non-pliable. They get stiff. They can't flow freely. They cause exacerbations in the joints and cause a lot of pain. The sickled cells get trapped in the vessels, causing an occlusion, like an ischemia or an infarct. That episodes are so painful. When they have an exacerbation like that, they're generally in the hospital. They can usually break down within 20 days, but in the midst of that exacerbation, the kids are in the hospital on pain pumps and oxygen. And it is really, it's a hard thing to watch. Those kids suffer so much. A compensatory mechanism is increased in the reticulocytes and tries to get these kids through the crisis, but a lot of times, they'll have terrible pain in their stomach, long bones, hand, feet syndrome, when those cells are clumping up in those areas. Infection, they can cause them to have strokes. They have upper respiratory infections. The lack of circulation causes the ulcers in the legs. And so they're hydrated, they're oxygenated, and pain relief. So treatment is hop to it. They say hydration, oxygenation, and pain relief. We won't watch both of them, but we'll watch this first one because we're almost done anyway. Oh, whoa, sorry. Oh, it's not working. Hold on. Oh, it's unable to play. There's an error. So you can see her after today. She gives a really good example of sickle cell disease. It's a genetic disorder of the hemoglobin involving a single base of substitution of valine or glutamine in the beta chain, resulting malformed red blood cells. So they are in that shape that I showed you. They're not like the circular little lifesaver discs. And not all of them are sickle celled, but most of them are. And when they have an exacerbation, they get caught, they get stuck, and it really does cause a real tough situation for the kid. High mortality rate, less than 5 years of age. Splenic dysfunction begins at 6 months of age. They are on prophylactic penicillin. They take it BID 2 to 3 months of age. They start with that. Monitor for infection is constant because sometimes they may not have an infection in their body, but the exacerbation will increase the temperature greater than 101.5, and any kind of respiratory signs and symptoms. Splenic sequestration is a high vascular, susceptible to injury or infarct. The spleen occurs 6 months to 3 years old. These kids get very pale. And in case of an African-American child, and a lot of our 3 are African-American, you can't see because their skin tone is dark. You can see in their eyes, they don't have the red and, when you pull the lid down, it's pretty much white. Same thing with their tongues inside their mouth. The buccal cavity is very pale. Fatigue, they get terrible abdominal pain and an enlarged spleen, and then the cardiovascular compromise. So they're brought into the hospital, they're given hydration, they're put on the cardiac monitor. Difficult to breathe, and that would be because the red blood cells are not carrying the oxygen. So they are given oxygen and then pain medicine, and usually it's a pain pump that's continuous. Given blood as well. That's one. It's very difficult if they are the religion that doesn't allow blood transfusions, but we hydrate, oxygenate, usually morphine or dilaudid. It's a PCA pump, or they're getting it IV push Q to 3-4 hours. And then when you say non-pharmacological methods, they sometimes will do like a lot of helping them with like sound, music, meditation, that kind of thing, just to control the symptoms. Home management, they're on pain control, fluid, a lot of teaching, early identification of infections, and little kids get infections. If they have siblings, those little kids go to school. Sometimes these other kids are homeschooled. They bring back bugs, and they most definitely are immunocompromised, so they're at risk. Immunizations are important, and then to avoid any signs or symptoms of dehydration, they always want to be well hydrated. Another condition, hemolytic condition, would be hemophilia. It's a group of genetic bleeding disorders where there's a deficiency of the clotting factor. So you have the clotting factors A and B, and they bleed longer, not faster. So if there's a little cut, it'll start bleeding and it just doesn't clot. Clinical manifestations for prolonged bleeding, bruising, and spontaneous hematuria. There's blood in the urine. They will do a replacement of the missing clotting factor, the recombinant 8 concentrate, cryoprecipitate, or the DDAVP. NSAIDs, aspirins, any indocins, they're contraindicate. It's because they inhibit the platelet function. And then regular exercise and physical therapy is encouraged because these kids are so fragile. They're so fragile that, they can't afford one little bump, one little skip, scrape, because they don't clot. So it's really difficult for them. It's an inherited factor 8, classic type A. There's no cure. Avoid injury and meds that promote bleeding. So the NSAIDs. Really good nutrition, good dental hygiene with a very soft toothbrush. Sometimes the softest toothbrushes, but they have to definitely do good oral care. IV administration of the deficient clotting factor when they come in. Intracranial hemorrhage is a very, serious one. They're really careful with infants and babies. You see, it says prolonged nosebleeds, hospitalization. They'll sometimes put a plug in the nose, keep them on bed rest. They bruise very easily, warm, painful, swollen joints with decreased movements. And then there's a GI hemorrhage. So their urine can be colored, cola colored, coffee ground emesis. That means that they're throwing up. They could have a little bleed in the stomach or in the esophagus. And then the tarry stools also indicate, a GI bleed. I've seen one hemophiliac diagnosed at Cottage, and it was a tiny baby that got one heel stick that wouldn't stop bleeding. Like, very strange. I know you'll all see me do a heel stick on a newborn nursery, and it wasn't pouring out, it just wouldn't clot. So we had to call the NICU. They took the NICU. That baby did go to Children's, and it was actually diagnosed with hemophilia. It's a genetically inherited disease that affects the clotting factor of the human. Low production of platelet causes a lot of bleeding in and out of the body. So it is really an alarming, scary condition. Any injury. They're the kids that have to be taken care of very carefully, prevent bleeding into muscle and tissue. An acute treatment would be rest, ice compression at the site, and elevation. And then, of course, those clotting factors. There is a camp for hemophiliac kids. And the last camp that I heard of on the pediatric unit was in Utah. So these kids actually get to go. Each kid is afforded a nurse, and the activities are like, really tailored to these kids being safe. There's a lot of swimming activities and things like this, and nothing contact. And where they do activities, they're watched, they're taken care of, their meds are taken, and kind of maybe a respite for having such an isolated, tough life. So that's kind of, it says here, I had hemophilia since I was born. With proper treatment, I can do just about everything. And you can't catch it, so we can be friends. It means they bleed or bruise easily. They have to be very, very careful. But swimming, there was a lot of swimming at that camp, and water things to do, because of course it's not contact. The parents are really grateful for a camp like that. It's usually generally state funded, because it could be very, very expensive to do that, to have nurses and physicians on site, and like a small clinic where they could get the medication or the infusions that they need while they're there if something went wrong. So something to think about. That's pretty much what we talk about here for today, but I will give you some pointers on the quiz on Monday. So I did look at the quiz. It's not a difficult one. It's got a lot of different stuff, so you'll have to look at a lot of different areas, but fluid and electrolytes, there was probably 5 or 6 questions on different, metabolic, acidosis and alkalosis, and then talked about the pyloric stenosis, the celiac disease, and the Hirschsprung's, and an intussusception. So those were all what we talked about in the GI stuff. Talked about an acute API and what, surgical interventions are taken, the care of an acute appendicitis. For school-age children, I think there was a couple of questions kind of going back to the first unit that we talked about, all school-age children, different areas of that when you did that nice big project. So hopefully some of it stuck. There was pyloric stenosis. Did I mention that? And then just a few little weird ones on scabies, poison oak, a couple on scabies, cleft palate, and poison oak. So it's kind of a lot of different things in the mix. So F&E, Hirschsprung's, acute API, pyloric stenosis, scabies, cleft palate, poison oak, celiac disease, impetigo, intussusception, and maybe something about a school-age kid. So I hope that helps in your studying, so you don't say, what is the quiz about? I don't know if I'm even supposed to say what the quizzes are about, but I hope it helps when it narrows things down when you're going to study. I will be in the lab on Friday at 8 a.m. for a student that has to take a test, and then we'll set up. I hope to get everybody signed off on their insulin pen and injection. That way you can do that in the lab, and then we'll do the blood demo and the TPN. So please don't miss, because if we can get all of those things done, we're going to do it. So if there's help in the lab, we'll get everything done that day. We'll be there until 2 o'clock. So try to be on time. Be there at 5 to 9, unless you're taking a test at 8, then be there at 8. I'll see you guys. If you have any questions, send me a text message or an email. I'm going to stop this share.
Thank you.
Okay, thanks, guys.
Thank
See you
you.
Friday.
Thank you.
Thank you.